Gastro Foundation in association with Project ECHO, University of Mexico. The fellows present every second Monday at 6, and please note that the chat will be open for questions throughout the presentation. Today we have Dr. Isneen Hilmy, who is going to be talking to us about drug-induced liver injury. Enjoy. Over to you, Dr. Isneen.
Thank you, Nelly. Okay, so today we're going to talk about drug-induced liver injury. And before I begin, just like to thank my moderator, Nelly, for helping me out with the presentation, and as well as Project ECHO and Gastro Foundation to providing this platform. So basically the outline of the talk, I'll be talking about the epidemiology, the mechanism of DILI, the types, risk factors, clinical presentations, diagnosis, and how we approach a patient with DILI and management, and certain special circumstances that involves DILI. So looking at the epidemiology, the incidence of DILI is in general population is not really well known. We have extremely little data available from South Africa or other African countries. These are published population-based data, which mainly includes the United States, Iceland, UK, mainland China, and few other countries. So if you look at US, there's a incidence per 100,000 of 2.07 per 100,000. Iceland has an incidence of 19 per 100,000. And in mainland China, they had an incidence of 23 per 100,000. So these are actually patients who had presented to specialized hepatology clinics and patients who only had severe like DILI. So this may be one of the reasons why it's accounting for an overall low incidence of DD worldwide. And when you look at liver failure, so drug-induced acute liver failure is 1.6 per 1 million population. And it is important to note that herbal and dietary supplements account for 43% of DILI and 19% of acute liver failure. And this is a $30 billion industry. And as we know that these are not actually subjected to pre-market safety evaluations, even in the United States. And DILI is one of the leading causes for drug withdrawal and use restriction. So looking at the most common drug classes, these are based on large DILI populations from Spain, US, Latin America, and Iceland. And you can see the most common among Spain, USA, and Iceland are anti-infective, whereas in Latin America, it's NSAIDs followed by anti-infectives. So the antibiotics we use, they're commonly associated with DILI. And as you can see in this NEJM article in 2019, which was published, if you look at the top 4, it's one of few drugs that we commonly use, like amoxicillin, which causes a cholestatic mixed hepatitis. And you have isoniazid, nitrofurantoin, trimethoprim, minocycline. So one has to be really careful when we use these antibiotics. So looking at the mechanisms, we can see that there are reactive metabolites that are formed inside the hepatocytes, which can kind of covalently bond to these proteins forming the neoantigen. And these stays in the hepatocytes until there's release of DAMPs. These are damage-associated molecular pattern molecules, which are released when the hepatocytes get damaged. Along with it, these are the neoantigens, they also get released, and this leads to APC activation, which leads to signal 1 and signal 2 signaling, which kind of leads to T helper and T cytotoxic cells that are activated, leading to an adaptive immune response. So after that, either the patient can get a DILI, or if the binding of the drug or drug modified peptide it's weak, then the patients can go into a immune tolerance phase. Yeah. So when you look at the types of DILI, it is divided basically into direct hepatotoxic or intrinsically hepatotoxic toxicity. And then it could be idiosyncratic or indirect hepatotoxicity is the third category. So direct hepatotoxicity, it is intrinsically hepatotoxic, it is frequent, and it is dose-related, it is predictable, and it's reproducible in the animal models. And latency period, it's typically occurs within days. And if you look at idiosyncratic hepatotoxicity, it's quite rare, and it doesn't have any relation with the dose, or it's not not predictable, and it's not reproducible in animal models. And the latency, sometimes you can see from days to even years. Similarly, like amoxicillin, as you know, you can get a DILI even after 8 weeks of intake of using of the medication. And indirect hepatotoxicity, it's not that common, but and it's not related to dose, but it could be partially predicted, and it's usually not reproducible in animal models, and it also has delayed latency for up to months. And these are more common with the anti-neoplastic agents, especially the immune checkpoint inhibitors. Yeah. And these are typical, some of the phenotypes of drug-induced liver injury. So this is in, these phenotypes are listed in generally in order of frequency. So you can have a massive acute hepatic necrosis, which is commonly seen with paracetamol or aspirin. And these are direct type of liver injuries. You can just get enzyme elevations. So many agents can cause this, and you can also have idiosyncratic effects like acute cholestatic hepatitis, or mixed hepatitis, or chronic hepatitis. Sorry. So these are kind of the risk factors. So we can divide it into drug-related risk factors and host-related risk factors. Coming to drug doses, so intrinsic DILI was found to be dose-dependent, and consequently, the drug dose is notably associated with liver injury in intrinsic DILI, such as paracetamol-induced liver injury. And it also depends on lipophilicity. So if it's highly lipophilic, then these drugs can cause, promotes drug entry into the hepatocytes. And then that causes increased production of reactive metabolites, which we had discussed. And these reactive metabolites can again couple with proteins and other macromolecules to trigger an immune response. And sometimes you have these hepatobiliary transport inhibition, which occurs, especially the ATP-dependent bile salt export pumps. So some of these drugs, they actually inhibit this, and it can cause excessive bile accumulation, leading to oxidative stress and hepatocyte death, and leading to DILI. Sorry. And then you have host-related factors. So age, it is, so in the RUCAM causality assessment, they mentions that the age more than 55, which gives more points. But if you look at the large registries, especially the Spanish DILI registry and the US DILI network, so they fail to support this hypothesis that elderly people are more at risk. However, the Icelandic study, they actually demonstrated that the incidence of DILI was higher amongst elderly people. But then again, they noted that this could be because they are on many pharmacological medication that can cause DILI. And sex generally is not a risk factor for DILI, and alcohol, there's no evidence suggests that chronic alcohol consumption is a risk factor. However, uh, alcohol consumption can increase the risk of DILI caused by specific drugs, like acetaminophen or paracetamol, isoniazid, methotrexate, or halothane. And alcohol is a CYP2E1 inducer. So what it does, it increases the risk of paracetamol, which induces the hepatotoxicity by influencing the NAPQ1 formation, which is a toxic byproduct of the xenobiotic metabolism of paracetamol. The other thing is pregnancy. So pregnancy alone is not a risk factor. However, a lot of pregnant women, they end up getting antihypertensives like methyl-dopa, hydrolysine, antimicrobials, and even propylthiouracil, which can lead to DILI. And then we have different comorbidities. Comorbidities in susceptible obesity might be contributory factors. And coming to genetic factors, so genetic susceptibility may be important determinant of DILI, but we really have very limited data and understanding of this. However, there's the genomic wide association studies. They identified key HLA alleles that influence this for specific drugs. So clinical presentations, so it's you can have asymptomatic patient could be completely asymptomatic, or they can present with symptoms which are very highly variable. So asymptomatic patients, they can just have elevations in liver enzymes. So symptomatic patients, sometimes they can have fatigue, anorexia, nausea, vomiting, and right upper quadrant pain. And jaundice or pruritus can also be a presenting symptom. And it's very important not to forget nausea, because it's one of the predominant symptoms which patients actually can present with DILI. And of course, the hypersensitivity reactions like fever, rash, lymphadenopathy, eosinophilia, to commonly with phenytoin, sulfonamides, and allopurinol, and DRESS or SJS, especially in patients who have been started on AVRs, so antitubercular therapy. And it could be acute hepatitis, or if the hepatitis is more than 2 months, then patients can have chronic hepatitis, and patients can present with subfulminant or fulminant liver failure. And even patients can have chronic cholestatic liver disease, especially this entity called Venetian bile duct syndrome. So the diagnosis is actually very challenging. It's largely based on excluding all the other causes. And also we have to determine the causality by RUCAM model, that's Russell-Oakleff causality assessment model. So which kind of determines the temporal relation and latency. So the diagnostic element, it's very important to note the time of onset after the implicating agent has been started. This is called latency. And then once you stop, the patients will have resolution of the liver function test. And then whether there's recurrence or re-exposure, that's a re-challenge. And it's very important to have a knowledge of potential and most common agents that are likely to cause hepatotoxicity, and clinical features of liver injury and different phenotypes. And ALT, AST, ALP, and bilirubin are the standard tests used to analyze this. And we should also know that elevated LFTs for 2 months one should consider it as a chronic DIL. Regarding liver biopsy, it might not be available in every center. However, it's very helpful in excluding other causes of liver disease. And certain medications are associated with specific histological patterns of liver injury that could be helpful. And biopsy can also be useful when liver biochemistries or symptoms do not improve after the drug is dechallenged or patient remains jaundiced, and can also be used to assess the severity of liver injury which is present. And what qualifies as a DILI? So DILI can present, as I said, as a very heterogeneous phenotype. Liver biopsy is not available in most common instances, and these are the guidelines which for practical and scientific purposes. So for ALT should be more than 5 times upper limit normal. ALP would be more than 2 times upper limit normal. Or if you have a ALT more than 3 times upper limit of normal with an elevated bilirubin more than 2 times. So, and we also calculate the R value. So that's ALT over upper normal limit divided by ALP over upper normal limit. So if the ratio is more than 5, it's hepatocellular. If it is less than 2, it's cholestatic. And if it's between 2 and 5, then it's classified as a mixed pattern liver injury. So High's-Law, it's a very sensitive and specific predictor for drugs potential to cause severe liver injury. So it was by Hyman Zimmerman in 1960s who discovered that a combination of jaundice and drug-induced hepatocellular injury was associated with up to 10 to 50% fatality rate from liver failure. So the initial High's-Law, which was used by FDA in drug development, was ALT more than 3 times upper limit of normal and a total bilirubin more than 2 times with a significant ALP increase. And then the Spanish DILI registries, they came up with this new High's-Law, which takes into account the ALT or AST, whichever is the highest, divided by its upper normal limit over the ALP and upper normal limit. And if it's this ratio is more than 5 and a bilirubin more than 2 times, and what the difference is basically the specificity. If you look at the sensitivity, it remains stable at same as 90, and the specificity has increased from 44 to 63%. So this is in the ASLD guidelines. Basically, this is the approach. So once we have made a biochemical evidence of liver injury meeting one of these criteria, like AST or ALT more than 5 times, or ALP more than 2 times on 2 separate occasions, or if you have raised bilirubin more than 2.5, or if you have a high INR, and then you suspect DD based on clinical history and symptoms and physical examination. So basically we have to assess exposure to all the prescriptions and over-the-counter or any herbal products or any toxins that the patient could be exposed to. And we have to know what are the starting and stop dates, especially if it's within the last 6 months. And we discontinue all the non-essential medications or any supplement patient is taking, and we determine the R ratio and classify the patients into hepatocellular, cholestatic, or mixed. And this will help us guide our further investigations. So it's a really extensive bit of investigations. We need to rule out all the other causes. So if the patient has hepatocellular or mixed pattern, we need to rule out like viral hepatitis A, B, C, E, CMV, and EBV or HSV should be ruled out. Also, if the patient has history of hypertension, sepsis, heart failure, we should consider ischemic hepatitis, autoimmune hepatitis, and alcoholic hepatitis based on history and labs. And we also have to take history of drug and toxin like mushroom or paracetamol poisoning, the serum APAP levels can be used, or urine tox screen can be also used. And other conditions like Budd-Chiari syndrome, Wilson's disease, alpha-1 antitrypsin, hereditary hemochromatosis, fatty liver, celiac disease, rhabdomyolysis, and hypothyroidism or hyperthyroidism should be considered. And if the patient has a cholestatic pattern of injury, then we need to see if there's any bile duct stones. So uh, we can do an ultrasound for that. And we also have to rule out if patient has PSC or biliary strictures or any tumors or malignancy, especially lymphoma and other bone diseases or TP and cholestasis. So this is livertox.gov. So basically, we can just go to this website and then we can look up different drugs. So it has most of the drugs, and you can either search by the alphabet, or you can just go there and then type suppose augmentin, and then we can click on augmentin. It will take you to kind of a brief overview of the medication, and then it tells you that what are the hepatotoxicity and when, how many days. So it says around 8 weeks, and then it also gives information regarding the pattern, the pathogenesis, and other HLA associations. So quite a useful website to refer to. So coming to management, so the most important thing is to stop the suspect drug, and if you suspect it's acetaminophen or paracetamol poison in N-acetylcysteine is the antidote, so it's very important to keep that in mind. And also, if patients got high INR more than 1.5 with mental changes, always think of transferring to a higher center where you can do liver transplant. And regarding the options with limited data, with corticosteroids can work for autoimmune or hypersensitivity cases. And for cholestasis, also deoxycholic acid can be used.
Okay, so sorry, Isneen, if you wouldn't mind me just interrupting, maybe give you a water break. So once again, thanks everyone for joining, especially for those who joined us a little bit late. So we're talking about drug-induced liver injury, and so far Isneen has shown you patterns on how drugs inflict injury to the liver. It's a very difficult diagnosis to make, as there isn't much out there, especially reported locally. But if you look at epidemiology in the developed countries, you can see, especially for those who've got some clinical experience, that most of the drugs that are reported or rather end up giving patients severe injuries that land them in hospitals are drugs that we commonly use, your antibiotics or your antivirals, your anticonvulsants, and your non-steroidals. But underreported and possibly missed most of the time is your herbs and toxins. People take these every day, and no one ever really think that they could lead them to hospital or be the cause of the those labeled idiopathic liver failure or chronic liver disease. I mean, you see a lot of patients from the rural Eastern Cape or villages presenting with vanishing bile duct, and if you take good history, you'll find that they would have been exposed to alu. So drug-induced liver injury is a very challenging topic and a very challenging diagnosis to make, even if you use the best scores. But what I want to emphasize, especially for the fellows or the most junior doctors here, if you see a patient who's got abnormal liver function tests, don't ignore them. Great detailed history is often clue to your differential and your diagnosis. And he's given you a exhaustive list of possible things to exclude. And patients who have rising enzymes with markedly or elevated bilies, be it 2 times the upper limit of normal, need to be admitted and worked up and the diagnosis made early, because we know that patients who develop liver injury or liver failure rather, sometimes we often lose them. So I thought just before he goes into management of commonly seen drugs that causes or use drugs that causes liver injury, I will recap, and also to remind people to please post questions in the chat, and for the senior clinicians who, if they have anything to add, they're also welcome to make comments or questions in the chat. So Isneen, I hope you had a minute or so to catch your breath. You can continue.
Thank you.
Thanks.
So just coming to paracetamol liver injury. So in paracetamol overdose, we know that there's a N-acetyl P-benzoquinone So it's excessively generated, and it leads to depletion of glutathione, and it gives rise to mitochondrial oxidative stress, causing mitochondrial damage. So this kind of induces the ATP depletion and opens up the mitochondrial permeability transition pores that contribute to mitochondrial protein translocation, and then it causes DNA defragmentation and causes the necrosis, leading to delay. So in this slide is also from ASLD. So I just wanted to mention the N-acetylcysteine. So it could be given oral or intravenous, and intravenous doses. So 150 mg per kg loading over 15 to 60 minutes, followed by 150 mg per kg over the next 4 hours, and then over 16 hours, 100 mg per kg. And those who have evidence of liver injury, we have to treat for extended time till the ALT starts decreasing and INR is reduced. So we have to make sure that N-acetylcysteine, the bags do not discontinue, and the treatment should not discontinue at any cost. And coming to management of idiosyncratic DILI, it's pretty much same. We have to rule out all the other etiologies and discontinue the culprit medications, and then supportive care and transfer to a liver transplantation for transplantation if it's high INR and mental status changes. And regarding steroids in IDILI, so there's no RCTs to evaluate the efficacy and safety. However, in limited retrospective data, they found that steroids may be associated with improvement in women if it's a hepatocellular type of injury, or autoimmune-like hepatitis, or patients presenting with hypersensitivity features. And they also found that steroid treatment was not associated with either improvement or increased adverse events during that treatment period. What about IV N-acetylcysteine in non-acetaminophen ALF? So this is a bit older paper, so it was like 10 years back. However, it's a prospective double-blinded trial who had a primary endpoint was survival at 3 weeks, and secondary was treatment-free survival at rate of transplantation. So if you look at the etiology, 45 of them, they were DILI, which is the highest, followed by the HPV infection, and then indeterminate causes of 41. And then 26 patients were autoimmune hepatitis. So basically, if you look at the first graph, so this tells you about the survival at 3 weeks. So you can see that the patients, they were basically divided into NAC versus placebo, and then they were subdivided into whether the patients had grade 1 or 2 HE or 3 or 4 HE. So you can see the early grades, whether it's placebo and NAC, they had good survival at 3 weeks. And even if you look at the transplant-free survival, it's better for the lower grade. However, if you see the placebo and the lower grade, it's still low. So this actually doesn't tell you that acetaminophen works, or maybe it's just that patients with low grade were anyway going to improve whether we give NEC or not. So it's really debatable. So this is the development and progression of ideally. So it is increased susceptibility, and then there's initiation of injury with elevated aminotransferase. Either the patient has adaptation and revolves despite continuing therapy, or the patient develops clinical manifestations like nausea, vomiting, fatigue, or liver dysfunction, or jaundice. And then from there, either the patient gets the liver undergoes regeneration and repair, leading to cure, or the patient goes into liver failure or severe liver injury or liver failure or death or liver transplantation. So clinical course of DILI can be very severe. So in this study, they found that 1 in 10 patients die or undergo liver transplantation within 6 months of onset of DILI. And 1 in 5 of the remaining patients have persistent liver injury even at 6 months. So it's not a benign condition and it can be very severe. So just something on TB DILI. So TB is quite commonly seen in our context. Patients can be either asymptomatic or symptomatic. And if the patients are symptomatic, then we look at the ALT, if it's between 100 and 200, we monitor weekly for jaundice and other symptoms of DILI. However, if the ALT is, it should be more than 200 or bilirubin more than 34, then we admit the patient, we stop all the TB treatment and other hepatotoxic drugs which the patient might be on, and then we also calculate the R ratio. And if patient is asymptomatic and the ALT is between 40 and 100, we continue TB treatment. And if the ALT is more than 5 times, although the patient is asymptomatic, we still admit the patient, stop treatment, and for patients who do not get admitted, we can follow them up after 1 week. If the ALT is improving, then the patient can be followed up after 1 month. And if the ALT is unchanged or increased, then we keep on weekly monitoring for the next 4 consecutive weeks. And if the ALT is more than 200 or total bilirubin is more than 300 or symptoms develop, then we admit the patient. And so after admission, it is important again to see whether it's a hepatocellular or cholestatic pattern. And based on this, as I mentioned, the investigation would differ. And after you have excluded all other causes, then after the management, we check the INR, blood glucose, and we start the TB background regimen with levofloxacin, ethambutol, or linezolid. However, if you have a rash, we have to be careful about ethambutol, and we avoid linezolid if the HB is less than 8, and amikacin or terazidone can be used if any of these combination drugs are contraindicated or unavailable. And of course, amikacin, we have to be careful about the EGFR. If it's less than 60 or raised INR, we avoid amikacin. And if levofloxacin is not available, moxifloxacin can be used alternatively. So these are basically the guidelines. So once the ALT is less than 100 and the bilirubin is normal and the patient is asymptomatic, then we can consider for rechallenging the TB treatment. And we do not rechallenge first-line TB treatment if the patient presents with acute liver failure. So these patients, they go into the background regimen. So if once we are ready to re-challenge, then either we can start with rifampicin. So although the guidelines and say 10 milligram per kg, you can always start lower and then titrate up. And then after 3 days, we repeat the ALT, and if everything is in order, then INH can be introduced. And you only, and after, on the day 7, you can consider introducing pyrazinamide, but only if the patient has severe forms of TB or patient is resistant or intolerant to rifampicin or isoniazid. So if not, we continue the patient on HRE. And on day 10, we repeat the ALT again. And if ALT is less than 100, if we can stop the TB background regimen except for ethambutol, and then we repeat the ALT weekly for a month. So these are just so what if the patient is not able to tolerate rifampicin, we stop rifampicin and start a shorter regimen for rifampicin resistant TB treatment with normal INH levels, and we continue it for 9 months. If patients are unable to tolerate INH, we stop isoniazid, and if the patients get pyrazinamide re-challenge successfully, then we continue rifampicin, ethambutol, levofloxacin, or moxifloxacin, and pyrazinamide for 6 to 9 months. And if the patients are not re-challenged on pyrazinamide, we just continue the rifampicin, ethambutol, and levoflox or moxiflox for 9 to 12 months. And patients who are unable to tolerate or who was not challenged on pyrazinamide, as I mentioned, we just continue in both instances rifampicin, isoniazid, and ethambutol for 9 months. And don't forget to monitor ALT for 4 weeks every week after re-challenge. So what about ARVs and DILI? So all ARV classes have been associated with hepatotoxicity. And you can have mild elevations, which is common, and generally they are very transient. And DILI occurs more commonly with nevirapine and efavirenz. However, we don't now normally use nevirapine, and even efavirenz, we have kind of moved away from that to DLG. So efavirenz, it's recognized as an infrequent cause for DILI. However, they can present with severe jaundice and raised INR, and usually the liver biopsies, they can show a submassive necrosis. And this may or may not be associated with hypersensitive rash, and often they are actually associated with jaundice and abdominal pain. And the overall mortality rate is around 11%. And generally after a long generally we see DILI after long duration, like 3 to 6 months of efavirenz treatment, and usually it takes even more than 6 months for LFT to normalize once we stop efavirenz. So according to the ART guidelines, they don't actually recommend routine monitoring of LFTs unless the patient develops signs and symptoms of hepatitis. So like nausea, vomiting, or upper abdominal pain, or jaundice. And then we check the ALT and ALP, and these are the kind of suggestions. So we stop the drug if patient has high bilirubin, or if the patient has ALT levels more than 5 times upper limit of normal. Anything less than 2.5 times upper limit, we can keep close monitoring with 1 to 2 weeks of repeated testing. So what about patients who have TB and ARV DILI? So these are kind of risk factors for patients to develop DILI when the patients are on both treatment. So one of the risk factors is more than 35 years of age, females, pregnancy, hepatitis B or C co-infections, or isoniazid-induced DILI, uh, and then malnutrition could be a cause. So if the ALT is more than 100 and patient is symptomatic, or if the ALT is more than 200 or 5 times upper limit of normal, or if the bilirubin is more than 34, then we stop both treatments. And then the important thing is we only restart ART only after completing the TB drug-free challenge. And so in patients who develop nevirapine-based regimen, so it's not commonly used, so we don't really see it. So in efference-based regimens, we do not re-challenge efference even in asymptomatic DILI. So if patient was in efference, we switch to a protease inhibitor or integrase inhibitor. And then we monitor the LFTs every 2 weeks for the next 2 months. So moving on, so statins are commonly used, and there was this study that studied statins associated with DILI. So they actually flagged around 64 patients with statin-induced DILI, but after vigorous thorough examination, they concluded that only 22 patients out of the 188 patients had DILI from statins. So it's there's a lack of distinctive phenotype in these patients. It could be mild and severe, it could be short and or long latency. You can get a cholestatic or even a hepatocellular pattern with statins. And clinically significant liver injury is very rare, and it's dose dependent. And individuals with underlying liver diseases are not associated with risk of statin hepatotoxicity. So it's often blamed, but rarely the culprit. So coming to autoimmune hepatitis due to DILI. So this is a clinical syndrome, and it resembles something of acute autoimmune hepatitis. So basically you can have autoantibodies or IgG in these patients, and they respond very well to steroids. And they commonly, they could be because of nitrofurantoin, minocycline, or TNF-alpha antagonists. So the most important characters are cirrhosis and fibrosis at presentation, and the progression of cirrhosis, and the drug withdrawal. So in drug-induced autoimmune hepatitis, you don't have relapse after drug withdrawal, whereas in classic autoimmune hepatitis, you can have relapse after the drug is withdrawn. And then immune-mediated DILI. So this is a type of indirect DILI, the third type of DILI which we were talking about. So in immune-mediated hepatitis, pancreatitis, or cholangitis, so these are patients who have been receiving or previously received immune checkpoint inhibitors, especially the PD-1, such as nivolumab, which is a second-line treatment for advanced HCC. We don't commonly see patients on this drug in here, but I've been told that in private sector, they do have it. So in patients who develop grade 2 or greater hepatic adverse events on anti-PD-1 therapy, so that means the patient has transaminitis with bilirubins more than 2.5 milligram per deciliter, or a coagulopathy of more than 1.5 without hyperbilirubinemia. So if you have, we generally do refer all these patients to hepatitis. And the evaluation, again, we need to rule out viral hepatitis, autoimmune surges, and anti-smooth muscle antibodies have to be done. Abdominal ultrasound to evaluate the hepatic and portal veins. And as per the guidelines, they put patients on, if the patients have grade 3 or 4, so that means very severe hepatitis, then they treat with 1 to 2 milligrams per kg, or if it's lower, it's 0.1 to 1 milligram of kg. So these are all treatment in guidelines. So if they're not responsive, then we do go for liver biopsy, but maybe liver biopsy could be done earlier on the algorithm as well. And for maintenance, we can switch the patients to mycophenolate MMF or tacrolimus. Just final thing on immune-mediated hepatitis. So if you have autoimmune hepatitis, mostly you have the ANA, ASMA, and IgG levels are high. And immune-mediated hepatitis, it usually is negative, but sometimes patients can have a positive ANA. And it is the distinction is mainly by the pathology. So once you have a liver biopsy, you can have lymphocytic or lymphoplasmacytic portal tract inflammation in autoimmune hepatitis, and where you have mixed inflammatory infiltrates, including T cells and eosinophils in immune-mediated hepatitis. Thank you.
Thanks, Isneen, for an excellent overview for a topic that is really, really difficult and challenging for most clinicians. And I'm sure everyone in the audience can relate to all of the drugs that you have discussed this afternoon, or this evening rather, as causes of drug-induced liver injury. And again, I just want to reiterate that, key in managing this patient is to identify an offensive drug or offending drug and stop. Patient's survival depends on it. Also to highlight that ideally patients who present in acute liver failure should be managed in centers that offer liver transplant, and that is ideally. If a patient is unstable, however, it's best that that patient is kept in that hospital and the brain is looked after, as most of these patients will succumb from cerebral edema and herniation. Again, for, where Panado is concerned, Panado, AKA paracetamol, unfortunately, our patients succumb to this if it's not picked up or diagnosed or treated early. And, most clinicians, especially the junior doctors in the ER, tend to wait for the levels before initiating Parvolex. And I just want to emphasize that if a patient comes to you and they say they've swallowed a handful of paracetamol, it's best to start Parvolex immediately while you're waiting for your blood results and your paracetamol level. There is no treatment except for Parvolex. Even if you refer them to Grooteskier or to Charlotte Maxeke, where they've got livers readily available, Parvolex is the key managing patients with paracetamol overdose. And the pain for every clinician, I'm sure in this audience, is managing patients who have TB and are on ART and are on Bactrim. It's important, even though there's guidelines, that you individualized therapy for these patients. I know the guidelines say start with this and start with that. Patients with, advanced TB are very difficult to manage, especially when they develop drug-induced liver injury. So therefore, we recommend, especially in our center, that we have a multidisciplinary committee. And that's when personalities, show off between IDs, specialist, hepatology, and GIT in trying to, work out the best regimen for the patient. So once again, thanks, Isneen, excellent overview. And I think we've got a few minutes to open the floor to questions. I see there is something on the chat. It's from Dr. Zamo. Thanking you for your excellent talk, which I agree. Could you reintroduce TB treatment sequentially or at the same time in mild to moderate TB DILIs? Zamo, it's a tough one, because often if one has had a liver injury and you reintroduce the drug that was potentially offensive, they might have a more severe injury. So our recommendation is if patient has got overwhelming burden of TB, if they develop a significant liver injury, as Isneen has indicated, ALT more than 5 times the upper limit of normal, that also is debatable. You stop the drugs, you give them a backbone, and you reintroduce drugs one by one. Often we are able, especially if they've got mild injury, we are able to reintroduce RIPA4. But if they've got enzymes nearly in the thousands, usually just end up with, or successfully just reintroducing rifampicin and isoniazid. So no, I wouldn't recommend that you give them all at once. I would recommend that you either start with, rifampicin or isoniazid. Again, he highlighted his name there that some people will go on straight. So just give, boom, 600 milligrams of rifampicin. But I err on the side of caution and start slow and build up, because some of these drug injuries can. So yeah, I mean, there's no right or wrong way. I always believe that in medicine, steady does the trick. And if you're patient, you might be able to save a patient and get away with actually reducing drugs that patients need the most. I don't know if that answers your question, but I see VG might have more wisdom to share. So VG, I will let you take over.
No, I don't have any further wisdom to share about anti-tuberculous drugs and liver injury. It's a bit of a, we don't really have very good evidence as to what will be the ideal approach in every patient. And I agree with you about sometimes you have to individualize it. And, in consultation with ID or tuberculosis specialists who probably more frequently see these cases. The question I actually have a question of my own to Isneen and maybe Neliswa as well. In your reading for risk factors, did you see anything about that those who have a pre-existing cirrhosis or a chronic liver disease are at higher risk for liver injury from your drugs?
Yeah, you can take it, his name. I think he briefly mentioned on it, but I'll let him.
I heard you say alcohol, but I mean, if someone's got cirrhosis or a pre-existing liver condition, then those individuals are generally, we were generally told they are higher your risk for developing a liver injury from whatever drugs they may have been given.
So according to the what I read, it was they had said about diabetes and obesity that may be a risk factor, but these are all not proven. However, in patients with TB and ART delay, if the patient has coexisting Hep B, Hep C, co-infection, there might be more risk. And yeah, so if it's even if you look at the immune-mediated delay, they say early referral to the hepatologist if patient has chronic liver disease, especially the patients who are on anti-PD-1 therapy. So I presume that acute chronic liver disease may have implications on it. Yeah.
No,
and then,
sorry, Vijay. Yeah.
No, go ahead, because I actually want to ask one more thing, or just make one more separate, comment.
Okay. So yeah, I mean, I think if a patient has got existing or known liver disease, they are definitely at increased risk of a severe actually liver injury. In patients who've got underlying chronic hepatitis B, they're at increased risk of INH related DILI. patients with liver disease tend to get, as you mentioned, Isneen, that patients who are diabetic, which are your metabolic associated liver disease, are at increased risk of developing severe liver injury. Whether they are prone to, or it's the injury that's sort of practice, or common practice rather, is we avoid known hepatotoxic drugs in patients who are known to have liver disease, and we drugs like sporins. Obviously, for patients where we know that there is no alternative, you cautiously introduce and make sure that you adjust the dose according to weight, and monitor liver enzymes and assess for any potential blip in liver enzymes. So severe injury for sure, whether they are increased risk, debatable, but I would err on the side of caution and be cautious when I'm prescribing any potentially or known liver toxic drugs like augmentin or your anti-inflammatory or non-steroidal drugs. So I think you said you had a second question.
Yeah, a bit more of a comment. So when confronted with liver injury, drug-related, cholestasis, if you've got cholestasis, the role of aerosol is still unclear. So observational, no solid evidence over there as yet, still sort of up in the air. The role of steroids, unless you've got really good supportive evidence that there's an autoimmune component, and this can be really hard because when you do the sort of histo on plenty of these patients with a drug-induced liver injury which has raised transaminases, you often find the pathology report coming back as showing you a bit of interface hepatitis. And you can get false positive autoimmune like markers, your smooth like muscle antibodies as well. So it is an area that I think everybody struggles with because of the absence of evidence as to whom should you give steroids to, and how soon, when, how much of evidence do you actually need. And with aerosol as well, I mean, aerosol you can, anybody with some cholestasis, if you have access to it, easy access to it, it's an easy thing to do. Let's just put the patients of aerosol and see what happens. But again, I don't think there's any strong evidence for it. In other words, many of those individuals may have improved just from withdrawal of the
drug,
ending agent of ending agent, irrespective of your steroids or your aerosol. Would you agree with that, Neliswa? It's still a little area that's a bit like gray.
Yeah, and listen, and like I said, I mean, I think in my opening, I said it's a very difficult diagnosis to make and a difficult diagnosis to manage. And key to managing is to even diagnosing drug-induced liver injury is to, stop offending drug or potentially offending drugs and see what happens to liver function. With regard to steroids, in my almost 20 years of practicing as a clinician, I always say no patient must die without ever being exposed to steroids. When desperate, throw in steroids, and obviously with caution in patients who've got liver failure. So, it's with experience and maybe more observation, certain drugs leave kind of certain, signatures or stamps. Let's look at patients who present a hepatocellular injury and with a hypersensitivity, reaction as in DRESS, you kind of can anticipate that if you do a liver biopsy in those patients, especially if the numbers are kind of going up like that, that you will see kind of an immune reaction. You'll see a lot of plasma cells, you'll see a lot of lymphocytes, and obviously if it's a drug, you'll see a lot of eosinophils. And what we then tend to do is we never really jump using steroids because we know that they can cause harm, especially in a patient who's got a very sick liver. But if what you see, the trend is going up and the INR is trending up, and you kind of, add one and one, you say this drug tends to cause this, and there is this hypersensitivity to maybe just curb that immune reaction or that allergic or idiosyncratic reaction. It's not unreasonable to introduce a little bit of steroids and see. If you wait, until INR is, in the liver failure ranges, then you might lose your patient. So we've done that a lot, and I don't know if you've come across Mark Sonorap's study on efavirenz. And that's where most, that's where most centers agreed. Those people kind of obviously stopped the ARVs, observed and supportively managed their patients without introducing steroids. We, even though our data showed that, I think I was early in my training and I kind of saw all of those devastating outcomes in patients who had efavirenz, fulminant or subfulminant liver failure. We didn't take decisions to introduce steroids lightly because you kind of felt when they go south from sepsis, did the steroids contribute? So I take your point that there isn't much evidence, but sometimes to just observe and stand on the sideline without at least doing something that is, somehow calculated, it's not unreasonable. So the use of steroids in drugs that cause, an immunoallergic reaction is not unreasonable, but definitely not at 1 milligram or 2 milligrams per kg. At most, we will give these patients, irrespective of weight, about 20 milligrams just to keep them, or to kind of like, I don't know how, I can't find the word, but to just stop.
We usually go the other way. And again, once again, there's no good research on this and trials on this, how much steroids to give, at which, in who, at which time, etc. So we usually go the other way. When we do make the decision to start steroids on an individual like this drug-induced liver injury, we usually go higher. We go about 1 milligram per kg. But I have to say we don't. Yeah, but I have to say we don't go over 40. So we go higher, and once again, who's wrong, who's you're right? Maybe the answer is somewhere in between.
Yeah, again, if you can get a biopsy and you see that there's lymphoplasmacytic, I think it's not unreasonable to give steroids because that's how we treat autoimmune, and autoimmune hepatitis actually, has those features. And just briefly on ESO, I love ESO. I think it's a great, bile acid. We tend to use it a lot in patients who come in with augmentin injury to protect those ducts that are swimming against the current and trying to fight the effects of augmentin, because we know that augmentin can have devastating consequences and can lead to chronic liver disease. So if a patient comes in and they are cholestatic, we try and protect whatever bile ducts that are to regenerate by using ESO. And again, you're right, there's no studies that have been published, but we know that ESO is a friendly bile acid. So it's not unreasonable if you have it to start it.
I've been over the years now, because like I said, these patients are often referred to us, both the liver injury with high transaminase and the hyperbilirubinemia, like cholestatic ones. And every year or so I go and try and look at the most recent review on it, and systematic review or Cochrane review on both urushiol and steroids. And there's no clear answer to use or to not use. And so it's still one of those areas, if you are asked in your exam, would you use it? I think you can say yes, but you have to then qualify it, or you can say no, and then you're going to have to also say how come. But we have.
But if you say no, we're going to ask. Listen, I think it has been an exciting and an interesting topic, and I think it probably, if you want to cover it quite extensively and have a fruitful debate, it needs to be broken down into more than just 1 hour. But once again, Isneen, I'd like to thank you for just summarizing a very, very big topic and share very relevant information with the fellows. And thanks, VG, for entertaining the discussion. Also, I want to thank the ECHO and the India team for the support. And just to note that this discussion or this presentation will be available on the website, thanks to the Gastro Foundation. Please do not forget to join in 2 weeks, the 2nd of is it the 2nd or the 12th of June, the 12th of June rather, where Dr. Kandlana will be talking about assessing nutritional status and management of sarcopenia in patients with chronic liver disease. And chairing that session will be our Queen of Hepatocytes, Professor Wendy Spearman. Thank you, everyone, for bearing with us. And I'm sorry that we ran a little bit out of time. Have a great evening.
Thanks, everyone. Bye now.
Bye. Thank you. Thanks, VG.